So Mike Postow, so this patient then, 75-year-old female, she has a BRAF wild-type tumor. She has a fairly small amount of disease with lung metastases and subcutaneous metastases. What are the treatment options if she was seen at your center in New York for her?
Okay, well, thank you, Robert. So for this patient, she's 75 years old, and she has very, very minimal amount of metastatic disease burden. So in this patient, knowing that she does not have a BRAF mutation, I would take the BRAF and MEK inhibitors off the table, and then I would be thinking about an initial immune therapy for this patient. And then the question would really be, is this patient that I should give immune therapy to, should I give a PD-1 drug by itself, or should I think about PD-1 in combination with a drug like ipilimumab? So for this patient with very low volume metastatic disease involving the subcutaneous tissues and lung, I would feel very comfortable starting this patient on a single agent PD-1 inhibitor such as nivolumab or pembrolizumab as a first-line treatment approach. We've known that the groups of patients with small lung metastases can do very, very well with single agent PD-1. And although we don't have a perfect predictive set of clinical variables or any kind of correlative variables that tell us who exactly can benefit from PD-1 monotherapy versus who may need the combination, I think this would be a patient I'd feel very comfortable treating with single agent PD-1 blockade.
And in these patients then, how long do you treat them for with the anti-PD-1 therapy?
So that's a very good question, because we know that thankfully PD-1 therapy as a monotherapy is a very well tolerated approach, and so we have patients who are responding to PD-1 treatment, some of whom have complete responses, and they've been on treatment for quite a long time, and it's hard to really know how long to continue these patients. So in our practice, I think what we can now use are some data that Caroline Robert presented at ASCO this past year, and that patients that have been treated with pembrolizumab in the KEYNOTE-01 study that attained a complete response of treatment on average for about 2 years of therapy, those patients have discontinued PD-1 and 97% of them remain in a complete response. So that is some reassurance that patients with complete response may be okay to discontinue PD-1. However, follow-up is still short, and so I'm still not quite sure. It's an ongoing conversation with each patient on a risk-benefit analysis, weighing the toxicity the patient may be having, weighing the particular response characteristics. We don't really quite know how long to be on PD-1. I think that's one of the most important issues in our field.
So Georgina, I know you in Australia have looked at sort of the concept of response and trying to assess this radiographically and trying to determine when the patient has had a complete response pathologically, although radiographically we may still see the patient have some tumors there. Can you comment a little bit on that, how we determine then when the patient maybe pathologically have had a complete response but still has some lesions?
So, Robert, that's really an area for research. There's nothing that we can do routinely in the clinic that will actually tell us with confidence without surgically removing the remaining areas you can see on CT scan, without removing them and seeing that pathologically there are no melanomas. But there's really nothing you can do in the clinic to be 100% sure there's no melanoma, although there are clues. For example, a PET scan and a 100% complete metabolic activity may give you some confidence. But ultimately, it's about discussing, just as Mike did, the data we have on patients with resist complete responses. That's where we have the most confidence at this point in time, but with the lacking long-term follow-up. The only other thing I would say on this issue is we still don't have data on patients who we've stopped, who've had a great response, whether it be a complete response or a really deep partial response, the patients you're referring to. We still don't have data if you stop and they do recur, if they do recur, can they be re-challenged with anti-PD-1 therapy and will they respond? We have anecdotal cases, but we actually don't have prospective data answering that question. So that's another question in the field that we have yet to address.
Yes.
Yeah.
And then, Tony, in the approved therapies that we have at the moment, pembrolizumab and nivolumab, the scheduling for those are slightly different. One is given every 3 weeks, the other one is given every 2 weeks. Is there a difference then in the responses that we see, whether it's given every 3 weeks or every 2 weeks for these patients?
So actually they're not, Robert. The phase 1 trial of pembrolizumab included dosing at every 3 weeks or every 2 weeks, and there were several randomized cohorts within the large phase 1 trial of 655 patients, and the overall result was that there didn't seem to be much difference within the error of those cohorts, but some of them had 200 patients per arm. Also, the dose of both nivolumab and pembrolizumab does not seem to have much an effect. In fact, people who have taken out lymphocytes from patients and look for saturation of the receptor, it's very high at a wide range of doses. So it seems like in the majority, the dosing regimens that we're using, we're probably saturating the target all the time. And that means that then more may not be better.
Yeah. And Mike, living in Texas, you have long distances to drive, and many of these patients drive for many, many hours to come to your center for treatment. Are there practical aspects then when you try to decide which agent to put the patient on?
Absolutely, and again, I think I think the consensus is it would absolutely be reasonable to treat this patient with anti-PD-1 monotherapy. I think it would be reasonable to treat this patient with combination immunotherapy as well. We know that the Ipi-Nivo combination had a higher response rate than single-agent PD-1, and we have data. We don't know if it's a statistically significant difference, but numerically an improved relapse-free survival. Again, the data we're really waiting on is overall survival. What we do know is that the combination of ipilimumab and nivolumab has a much higher toxicity rate. And so, as you said, one of the keys in a 75-year-old patient that you would want to know is if this patient were to get ill, how hard would it be for this patient to be brought for medical care? And so getting to how far they are from your office or a local oncologist's office, what is their support system, really does sort of weigh in the decision of trying to balance the relative risk and benefits of the more aggressive combination immunotherapy versus the single-agent PD-1 therapy.
Yes. And in this scenario then, let's say if she was 50 years old, and instead of having just a fairly low amount of tumor burden, but she actually had quite a bit of tumor burden, both in the lung and in the subcutaneous tissue, but also liver metastases, and this seems to be progressing quite rapidly. Would that then sway you to do one therapy, the monotherapy versus the combination therapy in that setting?
I have to say, although again, these again are the cases that we all discuss with each other, you know, at this point, there's nothing that says that there's a difference between a 50-year-old and a 70-year-old in how well they're actually going to tolerate combination immunotherapy versus single agent. I do think for patients who have evidence that their disease has a more aggressive biology, it's a natural instinct to, again, use the more aggressive therapy as well. We do know that even those patients, though, can respond to PD-1 monotherapy and can do well in the long run. But I do agree for patients who do have signs of more aggressive disease, such as a rapid sort of increase in size or an elevated serum LDH level, that those factors do tend to support the rationale for using the more aggressive immunotherapy regimen.
Yes.